and then gently collecting the soft tissue and putting the tape there. So first you have to put the under wrap so that it works like a second skin and patient don't get irritation because of the zinc oxide. You take the appropriate length of the tape. दूसरा टेप नहीं है, another tape. पर मैं उसमें दूसरा टेप दूँ. This is छोटा वाला. So width of the tape should be appropriate. For the knee joint, I'll use this one, not this one. Okay, that's the problem you get. Sometimes patient has put too much moisturizer or the cream and the tape does not stay there. So make sure you advise patient to remove all the hairs and not to put any cream moisturizer. My model has applied too much of moisturizer, getting conscious for the camera. So that's why the tape is not getting fixed. I have to use another tape. I should have instructed her not to put cream there. And then you put tape. Make sure tape does not come on the lateral border of patella. Okay. And then put the tape. Sorry, this should not have come. It is coming all because she has applied the moisturizer. So this will initially tilt the patella. I'm not shifting the patella because if I shift the patella first, there'll be more grinding on this side. So what I'm going to do first, I'm going to tilt the patella and then I'm going to shift the patella. So on the second tape, I'm going to shift patella now. So this patella should start from the lateral border of the patella. And then again in the same way, I'm going to put the tape there. And before putting tape, of course, you have to assess the patella, whether it is inferiorly tilted, externally rotated, or internally rotated, or tilted, or shifted. There's a whole assessment for that. And based on that assessment, you'll be doing. Now, in case the patella is rotated, so you are going to correct the rotation also, correction of the rotation. So what I'm going to put the tape like that, one tape in that direction. And another tape in that direction. Now hold it and rotate it and then put it there. Okay. And then hold it and put it here. I'm sure it won't get fixed here also, but it is the rotation. So what I've done, I have done the tilting correction, then I've done the shift correction, then I've done the rotation. So first I have to correct the alignment of the patella, and next one I'm going to do the offloading of the fat pad. So I'm going to put the tape there and then collect the soft tissue and then put it there. Okay. While in case you want to do it on old people, I'll not use zinc oxide tape. Okay. And while I'll not use zinc oxide tape in case of old people, I'll use only the under wrap. And while putting under wrap, you need not give any soft tissue collection. You just simply fix it. There's no technique to fix this. But while putting the brown tape, I will be I'll be lifting the soft tissues at that time. So right now, I'm putting the tape there and not giving any glide. Now, while putting the brown tape, yes, I will be doing the glide now. Okay. So you can measure the tape. And see how I'm going to lift it. Now I'm going to put it there and collect the soft tissue. Okay. I'm collecting the soft tissue and then pulling the tape, fixing it there. This is offloading the fat pad. Same way, I'm doing it on the other side also. If you see, there's some fat pad offloading already taking place. So it will look like a muffin top, you know. So if you compare the other knee with this, you'll see the difference. So I'm going to put another tape here and then collect the soft tissue and then fix the tape. Okay, could you please put your other knee on top of it? Yeah. So if you look at the knee now, you can see the difference between the fat pad in the non-taped knee and the taped one. Sorry about the cream. Okay, so you can see the fat pad. There's a difference. It is more like a muffin top here, which is flat here. So these are the 5 techniques I would do. First is the anterior glide. After doing the anterior glide, I showed you the posterior glide. Then I also showed you the internal and the external glide, and then release of the retinaculum and the mobilization of patella. And after doing all the electrotherapy, cryopack, strengthening, stretching, manual therapy, when patient go back, I'll offload the fat, I'll correct the alignment of the patella and offload the fat pad. So this is what I would do to my patient having knee joint pain. Over to you, Nitesh. Thank you very much.
Thank you, sir. Thank you so much for demonstrating this so nicely and clinically. And I'm sorry for our viewers, your friends might not be able to watch it on YouTube for some time. There was some technical issue. Now we have rectified it and created a new link, which you must have seen on your chat box. Anyway, thank you so much, Dr. Deepak. It was wonderful, as usual, hearing you and learning from you. Let me also ask Dr. Bhave to come in, join in so that we can start. I'm already flooded with question and answer. Actually, there are more than 37 questions already on the screen. Dr. Bhave, can you hear us? I'm not sure. We can have Dr. Deepak as well together. Dr. Bhave, can I request you if we can?
Can you hear me now?
Yes, sir, much better. I think technology actually still like to play with all of us. Whatever we do, they are always a step ahead from us. And thank you so much, both of you, for joining us today and giving us such a deep insight about how to manage the knee pain. Let me start up with a question which has come for Dr. Anil Bhave. Where is the pain in medial condyle 2 centimeters below the joint line comes from? That's for you, Dr. Bhave.
So I believe that if you palpate the joint line and if you get pain, that is a intra-articular pain. It could be a muscular pain. It can be a medial collateral. As you know, there are 2 branches of medial collateral ligament. One, a deeper branch goes into the medial meniscus, and the superficial branch goes further down. That pain is a different pain than when you have a patient with osteoarthritis and you have pain about 1 centimeter or 2 below the joint. And if you palpate that with firm pressure, If that pain is there, it's usually from an inflamed subchondral bone. And what I mean by that is, as you load the joint, you get small microfractures of the subchondral joint, and once the subchondral bone, and once that happens, it is very painful. But then there is also pes and serious that goes around it. So the pes pain is on stroking the joint, stroking the skin, versus direct pressure pain 1 centimeter below the 1.5 centimeter below the joint line is more subchondral pain. And there is evidence of that in terms of MRI, where you see subperiosteal swelling in a patient with osteoarthritis. And it's very important to distinguish between that pain versus joint line pain versus pes pain, because your treatment approaches are very different in terms of how you manage it. If you have pain of the internal derangement of the joint, the manual therapy will work better. If you have more pes-related pain, your modalities will work better. If you have a subchondral pain, then you will have better solutions through unloading the joint, because you are taking the weight away from that joint. So the strategies of, there's evidence from Oxford that looks at, if you contract your muscles that insert into your IT band aggressively, you can reduce your joint load by 20 to 30% just by muscle activation, because each of those muscles, and namely the vastus lateralis, the tensor fascia, gluteus maximus, medius, all insert into our IT band. So tensioning those muscles produces a tension in the IT band that allows for unloading of the joint. So then your strategy of treatment would be different. So that's how I look at it in terms of my examination. Is the pain on stroking? Is the pain on direct pressure? Is the pain on the joint line? Is it a medial collateral ligament strain? Or is it more subchondral bone? And in older patients with a slight varus deformity, I suspect more subchondral bone. And as that bone collapses, the deformity gets worse. So there is a big role of therapists to play here, because remember this, in our world, as therapists has changed tremendously in last 2 months. Everything is going to be different now for next, I don't know how many years. And it's very important to give a simple solution to patients with knee pain and not having them to depend on drugs, medication, or total knee replacement. Every patient cannot have a total knee replacement. That's how I look at it.
True. And I think next question is for Dr. Deepak. I think somebody wants to ask you, what should be the repetition and duration according to FITT principle?
Could you please repeat the question?
What should be the repetition and duration according to FITT principle?
According to?
FITT principle.
What we follow, all those researches are conducted in different countries on different races. So it might be different for Indian people, okay? So what we don't follow those guidelines. What we do here is 5 to 10 repetition, and it has to be pain relieving, pain free. I don't go more than 10 in any situation, and less than 5 will not be the one which will work on the patient. So I'll go 5 to 10 repetition, and if you want to hold it, I'll hold it for 10 to 20 seconds, not more than that. But what I do is I follow the pain. Pain is your guideline. Maybe if you're following those guidelines, but it's still causing pain, I will not do it. So it is the pain I have to follow, not those guidelines. My patient doesn't come for those guidelines. My patient come for the pain relief. So I'll do in a pain-free way, whatever pain relieving the patient. The standard protocol I follow is 5 to 10 repetition, hold for approximately 10 to 20 seconds.
So Dr. Bhave, shall we continue with your presentation now for the remaining one?
Sure. I can go ahead and show a few cases. In the end, it matters what the cases are. So let me show you a few cases. I won't show everything, but I will show a few cases, okay?
Go ahead, sir. All yours.
So real quick, the case number 1 is a posture of the knee inflection. But in clinical examination, the patient is not truly flexed. So this is a postural problem of the knee. Now, what does it do? As Deepak showed before elegantly, This produces a lot of compressive forces on the patellar tendon and fat pad because he's in flexion all the time. So though he is not a flexion contracture, he has flexion posture from various things. It could be hamstring tightness, it could be hip flexor tightness. So this patient's treatment is based on the lower extremity biomechanical evaluation to see how you can get him out of this flexion posture to a more extended posture, because we don't like flexion contractures or flexion posture. Why do we not like them? Because the evidence is there that shows that even 1 degree of flexion contracture past 5 degrees increases the risk of total knee replacement by 23%. I didn't make this up. This is actually an article published by Zini and all that shows that. So what we have to do is not only focus on OA joint for varus, but also look very carefully at extension of the joint. And the tolerance of the extension should be nothing more than a couple of degrees. We should always have, so the cutoff is 0 degrees. You want a full extension posture in walking. It's very critical. You can lose 5 degrees of flexion range of motion and be okay. But if you lose 5 degrees of extension, it's a problem. And this is how we test it. We call it a prone knee hang test. And we want to make sure that the heel heights are matching to each other. So that's how we do it. And if you look at the gait study of the patient, you can see that they have varus, but they also are flexed in their gait when they walk. And what does that do? That's how they walk. And I'll show you. You look at the knee, it's flexed when it starts accepting load. Again, the same thing here. So we got to take these people out of the funk. One of the things that we haven't talked about is plantar flexor strength. It matters for patients if they are weak in their plantar flexors. And look at this, their knee flexion moment is much greater, their varus moment is not. So we always look at the combined effect of knee flexion with varus on all our OA patients. And I truly believe that osteoarthritis is not just a varus valgus disease, but it's a more flexion disease or a lack of extension disease, in my opinion, because it causes pain where the pain receptors are, in the fat pad, patellar tendon, quad tendon, posterior capsule. The next case I want to show you is this very horrible limping gait from very stiff knee. As you can see, she's walking with a very stiff knee, very painful gait, abnormal gait significantly. So how do we change the outcome of this patient? How do we change it? Well, we do lots of things. So I'm just going to show you bracing that I developed, extension assist bracing. We do deep tissue therapy. Therapy is only 2 times a week. And what are the types of results you can get with this? So I can show you. We use a very simple splint. We believe that scar tissue needs to be mobilized for more than just therapy. So they use a home stretching device like this with the TheraBand, very simple and easy to make. And you can get results like this. And you can see how nicely her knee flexion extension is. Her gait is almost normalized, almost normal. Look at that extension of the knee. Look at that flexion of the knee during walking. And trust me when I say that she has more than 110 degrees of flexion after her knee surgery. So you can achieve results like this as long as you follow the principles. Another case like that, post-traumatic, again, very difficult knee, pretty obese patient, but you can achieve results like this if you follow the principles that we have discussed. Is a biomechanical evaluation followed by appropriate therapy. It includes manual therapy, taping, electrical stimulation, bracing as required. Following those principles, you can achieve it. And the last case I want to share with you is a very interesting case of, this is a skyline view of the patella. So this is a view where you have the X-ray beam with knee inflection of about 60 to 80 degrees, and you do a tangential view, and then you get the patellar location. Now, normally the patella is supposed to sit here, but this is a lateral, this is medial, this is again medial, and that's lateral on this side. And you can see that there is attenuation of the vastus medialis and the tightening of the vastus, the retinaculum that goes into lateralis. There's even a slight osteophyte there because there is compression on the lateral compartment of the knee joint, but there's a lift off in the medial compartment. Now, most patients like this get a arthroscopic release of the lateral retinaculum followed by physical therapy. Well, this patient I treated conservatively, so we managed this conservatively. So this was I saw this patient 10 years ago, and actually I have a 10-year follow-up on this patient. I still talk to her, and she was a runner. So this kind of pressure on the cartilage, undue pressure with stretching of the medial side like this, is going to cause a lot of pain. Well, she was in a lot of pain. So what were her findings? Her findings were she's a 44-year-old female patient, normal weight, used to run up to 30 miles per week, did 7 marathons, no running for 1 year due to pain. 1 year history of pain with long distance runner. If you look at the small changes in rotation that can occur in large pressures areas, has been shown in the literature that once you have patella out of the socket, you can put 5 to 10 times the load that otherwise you put on your patella. So you have to be very careful with that. So what were the significant findings? It's tight IT band. I also have a test where you look at the effect of the IT band on the lateral retinaculum, especially put the patient in over position and actually mobilize the patella medial to lateral, lateral to medial to see how tight it is. She had weak abductor muscles, increased interrotation of the hip, slight pes planus, abnormal movement strategy for step down and lunge, and a slight knee flexion contracture. So we treated all of that. We had a home exercise program, we had manual therapy, we did 8 sessions of soft tissue mobilization with A-stim therapy, NMES, manual therapy for IT band, hip flexor, lateral retinaculum, kinesiotaping for facilitation, and McConnell taping for initial use. And we only ranged her within the Scott-Dye principle of ranging her within the range of motion. And we even used McConnell tape in a more creative way like this. This is not the same patient, but we use it like this, where we can do electrical stimulation and mobilize the patella lateral to medial and inferior, and also lateral like this to improve the patellar stability. We managed it later on with kinesiotaping as a carryover mechanism for when we discharged her from therapy. And the last X-ray shows us the picture. If you look at this on the top, this is her pre-physical therapy picture. Look at the lateral subluxation. She's almost 30% out of the socket on the left side and almost 25% on the right side. These can be very painful. And after 8 to 10 sessions of therapy with adequate strengthening of the VMO with using electrical stimulation, taping, manual therapy, we were able to get her patella in a much better location and good joint space. One of the things that the patellofemoral surgeons will look at is how much is the space here versus how much is the space here. And look at this, there is no space here, and there's minimal space here. So now, with balancing her patellofemoral joint, with physical therapy that included all the things that I discussed before, we were able to get joint space in both those areas of patella, and there was normal tracking. The good thing about this is that I follow my patients until they don't follow me, meaning that I keep talking to them every year. I talk to them, I bring them back if necessary. I believe in a model of physical therapy that should be a dental model. A dental model is patient is never discharged until they die. And I use that to some extent where I follow up with my patients. I bring them back for a tune-up. Just like cars need tune-up and balancing and tire changing, I think our patients need it too many times, and I bring them back. And that's how I keep in connection with the patients. And I was able to bring her back multiple times. I've been in touch with her for 10 years, and she's still very active, and she doesn't have much pain. She knows what to do when she gets pain, and we have managed her. This would have been 100% surgery, or may have had a patellofemoral replacement because she was so painful. And we have maintained her function for almost 10 years. So I just wanted to share that case with you. That probably is a sense of therapy, the way we manage our patients here. And the last case I want to show you is Patella Baha. What is Patella Baha? Patella Baha is when your patellar tendon gets too tight and your weak quadriceps and your patella starts sinking down. And patella alta is when your patella is too high because your quadriceps are too strong and this is inflamed and too weak. Majority of our problems in orthopedics are related to patella baha, where the patella is down. So I want to share with you a simple case of one case only, shows how a flexion contraction with patella baha, because I truly believe, like Dr. Deepak Kumar showed before, is that you need to have superior mobility of the patella to get extension, and you need to have inferior mobility of the patella to get flexion. And the total excursion of the patella is about 7 centimeters, and we need to achieve it. And in this case, the patella baha it's a shortened patellar tendon. The patella is sitting low. I have a nice guide here. The total knee tells me where the patella is and where it should be. So I measure it, and I work on the quadriceps strengthening. I work on patellar taping. I did unloading taping on him. And then we also did a lot of extension mobilizations. And you can see the patella is more realigned. And the fact is this distance, which is about 2 or 3 centimeters, has changed to less than a centimeter here because the patella is now riding, the knee is better. So you have the perfect, so if we can monitor our patients like this with x-rays, it's even better to document what we are doing here. So that is my last case that I shared with you. This is the nice view of Baltimore Inner Harbor, where I live, and I thank you all for joining us in this webinar. These are troubling times and difficult times, but we will all come through this, hopefully, very well. Thank you again.
Thank you. Thank you so much, Dr. Bhave, for again taking us through your experience while treating knee cases. It was such a wonderful. I don't think so we will be able to take up a lot of questions, but I'll try to cover up questions. Maybe, sir, we request you if you can stop your screen share. We will take up a question which has come more frequently. Like I can see this question is ice compression with elevation is best post-injury. Is it the best solution, Dr. Bhave? A lot of people have asked that.
I think so. I think ice with compression is probably the best treatment. With elevation is probably the best treatment for all knee injuries. But then we need to add a little bit of that rice into that, where we do careful range of motion. Because what if you do total rest, if you immobilize the patient totally, you have different problems, like you have scarring later on. So the rice needs to change to gentle range of motion with ice, compression, and elevation. That's my new rice.
So I think another question which is coming up again and again, what's the right age of getting a knee replacement for OA patient?
That's a great question. And there is no real answer. And I'll tell you why. Because there can be a 70-year-old who is physiologically 55 years old. And there's a patient who is 55 years old who can be physiologically 75 years old. The question that we have to ask as therapists, and this is what I debate with my therapist all the time, is when do you say enough is enough? And is every patient a candidate for total knee? Is the pain related to that? And many times, I think the reason why people are dissatisfied after total knee replacement is lack of education on what the expectation should be, and are they prepared to have a total knee done? If you are never squatting for 2 years before surgery, and then after surgery you want to go squatting, it's not possible. So the expectations have to be managed, number one. But my personal feeling is that there is, and I'm going to say this very bluntly, is that there is an overuse of total knee replacement in many markets around the world, including the United States. And the reason it has been is because the therapists have been missing in this whole picture. The osteoarthritis management has kind of given up by therapists. And it has gone to arthroscopy, which doesn't work. There's a lot of papers now showing that arthroscopy doesn't work. Meniscal lavage doesn't work. What works is careful management through the life of the patient with self-management, meaning exercise therapy. And I I believe osteoarthritis model is just like a car. If a car needs tune-up and balancing every 5,000 kilometers or 3,000 miles, we as therapists have a role to play in managing the patient. And there is a group of patients who will have intractable pain and what we call Kellegren-Lawrence 3 or 4, where everything else has failed. Yes, I agree. Those are the right patients for total knee replacement. But to not do a careful assessment and treatment of patients is not right, in my opinion.
Here, I would like to add one thing, Dr. Nitesh. Maybe many therapists might have seen this. There was an article published in Times of India a few years back. And this article was based on a study done in London. And the title of the article was Total Knee Replacement, Is It Overprescribed? So many times, again, I totally agree with Dr. Bhave. If the therapist is not actively involved and expectation of the patient, and then let the pain be your guide. When do you want to say enough is enough? And in my experience, majority of the time, if we are able to offload the fat pad, if we are able to treat the inflammation of the knee joint and correct the alignment of the knee and the muscle balance, you can extend, you can delay the total knee replacement for few more years, even in moderate or severe osteoarthritis. You can always delay it. And I always use a beautiful line I have stolen from Lakme. There's a beautiful punchline in the Lakme. They says, "Hum aapke kal ko parson mein badal dein." And this is what the physiotherapists also do. We change your tomorrow into day after tomorrow. You maintain the quality. So maintain the muscle balance, joint alignment, offload the fat pad inflammation, and you can delay it to a great number of days or months or years.
Great. Thank you. Thank you so much. And my apologies to all the viewers and the attendees because we can't take more than question. We are already over the time what was prescribed. Let me now welcome our president, Dr. Rajiv Parashar, who has joined us now. So, sir, anything from your side as a concluding remark?
Me in this webinar. It was a wonderful webinar once again. Professor Bhave and Professor Kumar, it was intoxicating listening to you, and I wish we could have continued more and more. Once again, I am humbled by the knowledge that you all have and the knowledge that you have shared with us during this webinar. The one last thing I would like to end with is that both of you sort of work towards what works. The techniques that you all have suggested, Bhave's NEMS, cold, rice, whatever he's talked about, Deepak's mobilization techniques, essentially talk about how things, what are the things that work, and what at the same time you all have entrenched it in evidence. This is the state of what physiotherapy today is going to be and the future is going to be. So what works and what is the evidence for that? Thank you once again very much. And Nitesh, back to you.
Thank you so much, sir. Thanks all of you for joining us today. We have a small feedback poll which will help us to plan our future. We already have some webinars planned already. I'm going to share the details with you right now. So meantime, we get a feedback from our attendees today. I thank Dr. Anil Bhave, who has got up so early today to meet up the timing. Dr. Deepak Kumar, as usual, you were fantastic. And Dr. Raju sir for providing this kind of opportunity for all of us to come and interact during this unprecedented timing and learn from the expert. Meanwhile, while we wait for the result, for the feedback, so that we plan our next sessions onwards, let me take up to you with our upcoming events, what we have planned for the rest of the
scroll their screen.
We also like to invite you to our 6th annual conference, which is scheduled for January 2021. And hopefully everything will be back to normal by that time. It's in Chennai. Log on to our website to get the more details. In case you want to know more about us, you can also connect with us on our Facebook page by name Society of Indian Physio. Once again, these are the details of our upcoming webinars, what we have scheduled for all of you for the month of May.
Dr. Nitesh, details are not displayed. If you could please share your screen. There's something, again, technical glitch. Please look into it.
Let me try that again, sir. Is it visible?
Yeah, now, yes, now it is coming.
My apologies again. Technology failed us and challenges once again. So these are the dates what we have planned for the month of May for all of you. Mark your dates. We are going to come back to you on every Sunday now onwards, except tomorrow, because we have planned for today, 10th, 17th, and 24th, where we're going to have 3 different webinars by, again, the experts within their own domain. The annual conference, which is the most important event for Society of Indian Physiotherapists, it's been scheduled for January 2021 at Chennai, January 8, 9, 10, and hopefully everything will be back by that time. Back to normal, healthy, and all of us can go out and travel and attend all these kind of events. My apologies to our audience whose question we couldn't take up today because of paucity of time, but we have shared the email IDs of our speaker. You can always write to them in case you want to ask them something specific.
Thank you to SIP for giving this opportunity to share our insight about the knee joint. And thank you everyone for attending this. Thank you so much.
And thanks from me too. This is Anil Bhave. Thanks again for all of you attending, and enjoy your evening.
Bye. Take care.
Thank you so much, sir. Thank you, Dr. Deepak and Dr. Bhave, for joining us today. Thank you so much once again. See you next Sunday. Thank you.
Bye-bye.